Okay, folks, I'd like to welcome you. I'm Mary Sue Lanigan. I'm the Executive Director of the Michigan Parkinson Foundation, and it looks like right now we've got 23 folks on the call. I assume we'll have a few more joining in. Tonight, we are really pleased to have welcome and thank Dr. Tom O'Neill. He's the Medical Director at NorthStar Palliative Care. He's also with Michigan Hospice, and I don't know, Dave Robinson might be also speaking as well. He's Director of Market Operations of Southeast Michigan. Folks, I'm going to go through and mute all of you so that we don't hear any background noise, and then hold your questions towards the end, and then we will open it up for question and answer after Dr. O'Neill is done with his presentation, okay? We're up to 26 people right now. All right, let's see here. Okay, Dr. O'Neill, you may, oh, I already have a question. Tim can see and hear you. We don't need to see them. Okay. All right, Dr. O'Neill, I think we can get started.
Fantastic. Well, thank you very much for having me. Today, I'm going to cover Parkinson's disease and palliative care, and there'll be plenty of time for questions at the end. Palliative care is something that I am very fond of. It's a passion of mine. After training at the University of Michigan for my family medicine residency, I did a fellowship in hospice and palliative medicine, and so this actually is my medical specialty. And Parkinson's disease, unfortunately, is a disease that is fairly common, and we care for a fair amount of folks with Parkinson's disease. So on behalf of myself and Dave Robinson, thank you all for having us. And without further ado, we'll get started. So these are my goals and objectives. I really just kind of wanted to talk about what is palliative care. Palliative care has been in the media now for a couple of years, and it's kind of a hot topic. You may have heard Atul Gawande. He wrote about palliative care kind of a number of times. And so I think people are starting to hear that there's this thing called palliative care, but I want to unpack the black box a little bit and kind of talk about what exactly is palliative care, what does it look like. Then I'll talk a little bit more about how does it work, what's involved in a palliative care consultation, how might that be different than a visit to a neurologist or a primary care physician's office, what's the focus of palliative care, kind of what makes it a little bit different, and why might folks engage the help of a palliative care physician. And then I'll talk a little bit more specifically about palliative care and Parkinson's disease. There's a number of studies out there about palliative care and Parkinson's disease, the benefits thereof, and they kind of compare it to ALS, which is another chronic degenerative neurologic disease. And so what they found is that folks with ALS tend to engage palliative care services earlier and have some better outcomes in terms of overall quality of life throughout the course of their disease, not just at the very end, but as they engage palliative services, even at time of diagnosis, their quality of life all along the spectrum is better. So a lot of the literature in palliative care and neurologic diseases centers around ALS, but there is more and more coming out about Parkinson's. So we'll talk a little bit about that too. So without further ado, let's jump to the first one and say kind of what is palliative care? Well, first, when you think of the traditional medical model, on the left-hand side of the screen there, you have prevention. And so that's usually where most folks spend, hopefully, the majority of their life. They go to their physician, they get their checkups, their annual colonoscopy, or hopefully not annual colonoscopy, but they get annual blood draws, immunization, so forth. Then at the time of diagnosis, the goal is to do everything. We're going to do whatever we can to fight your disease. And then as you progress along the disease spectrum, there reaches this point of futility, and folks are told at that point in their disease, sorry, there's nothing more we can do. And then they go into hospice and then they pass. I really don't like that phrase, there's nothing more we can do. In fact, when I was at the University of Michigan teaching medical students, I always told them, you can't ever use those words, primarily because they're a lie. There's always something more we can do for folks. Now there might not be anything more we can do for their cancer. They might not be a candidate for a heart transplant, but there's always things we can do for people, whether it's focusing on their quality of life, helping with advanced care planning, or just helping them say goodbye. There are always things we can do for folks. So where does palliative care kind of fit into this traditional medical model? Well, the goal of palliative care, as defined by the clinical practice guidelines here, is to prevent and relieve suffering, and it's accomplished through the efforts of pain and symptom management and other distressing symptoms, while incorporating psychosocial care, spiritual beliefs, assessing families' needs, values, beliefs, all within the background of their culture. So that's a very kind of nebulous way to define palliative care. To try and get a little bit more concrete about it, what we sometimes say is that palliative care expands the traditional disease model, expands the traditional disease model. To include the goals of enhancing quality of life, optimizing function, helping folks with medical decision making, and as such, it can be delivered concurrently with life prolonging care or as the main focus of care. And I'll talk about that kind of subtle but important difference there. A lot of people say, kind of, where's the term palliative come from? When the term was coined in the early 80s, it's from a Latin term that means to cloak. And so when you think about palliative care in the cancer patient, when palliative care is involved with the cancer patient, we're helping with their pain, we're helping with all of their suffering, and we're cloaking that pain and suffering. We're hiding the effects of the cancer, but unfortunately the cancer is still there. So that's kind of where that term palliative comes from. It's that Latin term to cloak. So what actually happens, I think now, as opposed to that traditional model of care, now there's more of a continuum of care. And you can see on the left, there's still the prevention aspect of disease. And then at the time of diagnosis of a serious illness, there's a focus on curative and life-prolonging care, as there absolutely should be in those early stages of the illness. But then if those treatments don't work and the illness progresses, you can kind of see there that there starts to be a little bit more of a focus on palliative care, focusing more on pain and symptom management. And then if the disease is still being well taken care of, the treatments and the interventions aren't burdensome, maybe palliative care takes less of a role. But then if the disease unfortunately kind of continues to progress, palliative care starts to take on more and more of a role. The disease becomes less and less and less of a focus. And what becomes more and more of a focus is, how are you living with that disease? How are you coping with that disease? And then finally transitioning more to that hospice phase of the disease towards the end. So you can see pretty clearly here, palliative care is involved in all aspects of a disease and any time during the continuum of care. So in brief, I tell folks, palliative care is a specialty like any other medical specialty. So you have a neurologist and a pulmonologist, and you can go ahead and see a palliologist or a palliative care doctor. And they work in concert with your other medical teams, but our focus is different in palliative care. What we focus on is quality of life and how you define quality of life. Is it being pain-free? Is it being more awake and alert? Is it making sure your loved ones are taken care of? Is it kind of focusing on dignity as your body starts to change? I think an important caveat with palliative care is it doesn't place any limits on the care that you can receive. A lot of people mistakenly believe, oh, he's on palliative care, so he can't go to the hospital, or oh, he's on palliative care, so he can't get chemotherapy, or he can't get this particular intervention in. That's not true. Again, palliative care is just like any other specialty. The focus, though, is a little bit different. But folks can still go to the hospital. They can still engage with all of their other medical services. So what I tell folks is that with palliative care, we're an extra layer of support in addition to your current medical team. I'll kind of talk about how that starts to play out here in a little bit. So what exactly does palliative care do? If you have that question, it's okay. You're not alone. I think I spend the first half of most of my palliative care consultations talking to people about why they're there in the first place. Most people say, "Oh, well, you know, I went to go talk to my neurologist, and they said I should talk to you, but I really don't know what I'm doing here. I'm not sure exactly how you can help." And so what I tell folks is that palliative care does three things. Number one is we're experts in pain and symptom management. So whether it's physical pain, whether it's shortness of breath for people that have heart disease and lung disease, fatigue is a big problem for all folks with chronic and terminal diseases. Constipation, appetite, mood, sometimes palliative care helps with mood, sometimes psychiatrists, we kind of play in that same sandbox there. But whatever the symptom is, the palliative care doctors are usually called in to help with refractory symptom management. The other thing that we are is kind of the big picture team. So I really encourage people when we're having a palliative care conversation, let's take a step back from the numbers. I don't care what this number was today and what it might be yesterday and what it was 2 months ago, but more kind of big picture wise, where are we now? Where do we expect to be going? And how can we get you the best care possible along the way? So let's kind of take a step back from the minutia of managing somebody with a chronic disease and start to think more and more about the big picture. And then finally, one of the things that palliative care does well is we help folks with advanced directives. So let's kind of unpack each one of those. So first with pain and symptom management, this is just a handful of symptoms that we manage. These specifically I looked up with Parkinson's disease and palliative care. These are the more common symptoms that folks manage with that have Parkinson's disease and that palliative care physicians have been called on to help manage. And again, anytime we're managing symptoms, one thing that we're always looking at is the risk and benefit of treatment. I tell folks, especially when it comes to pain management, I want you to be as awake and alert as possible, but also as comfortable as possible. And admittedly, for some folks, depending on their pain or how things are in their body, that can be a very fine line to start to walk. And so, but pain is the thing that we probably do the most, but fatigue can be a horrible symptom. Number one, it can be a symptom of too many medications. It can be a side effect of medications. It can be signs that the disease is getting worse, or it could be a sign that you just need more help at home. And so fatigue is another one of those areas that we tend to go into as well, although oftentimes with fatigue, it's not a matter of prescribing another medicine, it's actually taking away some of the medicines that might be causing that. Constipation is a big one. One of the champions of palliative care was Dame Cicely Saunders. And so she was in England. And so she started palliative care. She said, we need to do a better job taking care of folks with terminal diseases. And so one of the physicians from the United States went over there to work with her back in the late 70s, early 80s, before there was even such a thing as hospice. And so he spent all this time with her, and on his last day, he went in and talked to her. And he said, you know, what do I need to know about taking care of human beings that have these illnesses? And I think he was expecting kind of some grand statement about humanity and suffering and whatnot. But Dame Cicely Saunders just turned to him and said, mind the bowels. And that was it. So constipation is something that can be preventable. It's an unfortunate complication for a lot of medications, and it can be really painful. Anorexia and specifically not eating as much or loss of appetite. Fatigue I put on there twice because it is so common. Mood disorders sometimes have as a side effect of medications, or anything else that folks tend to be struggling with, insomnia, chronic cough, whatever the case may be. So pain symptom management is really the wheelhouse of the palliative care physician. The other thing is I tell people we're the big picture team. So again, taking a step back, not necessarily what's this number today or what is it yesterday, but where are we now? Where do we think we're going? And how can we get you the best care possible? And so what we do is we define the term goals of care. But when I'm teaching students about how to do this, I tell them, if you're using the words goals of care, you're doing this all wrong. Because I'll be honest, I do this for a living. And if somebody said, Tom, what are your goals of care? I'm not sure I could say that. But what I can say is, man, if I was going through this, this is what I would be really hopeful for. This is what I would be worried about. This is what I would be absolutely afraid of. These would be things that would be keeping me up at night. And I would want to work to find a solution to those things or just get more information about it. So sometimes in talking about goals of care and getting the best care possible, we talk about prognosis. How much time do you think you have left? Have you ever had that discussion with the doctors that are taking care of you? You know, what have they said? What does that mean to you? Having a good understanding about your prognosis is really helpful. So sometimes that's involved in this conversation, primarily because if you told me that I had 2 hours left to live, I would be making radically different decisions with my life than if I had 2 days or 2 months or 2 years or 2 decades. And so having a good understanding of prognosis helps people frame what their goals are. You know, notwithstanding, if you knew that, well, if this treatment works, I would have 2 more decades left to live, a lot of folks would be willing to undergo a lot more in the way of suffering as a side effect of that treatment, as opposed to if, you know, the treatment would maybe just give them an extra couple of weeks or couple of months. They might say, well, forget that if that treatment's going to make me feel miserable. So again, sometimes it's just walking and, you know, asking folks about what have you heard from the doctors about where your disease is at? Have you had a discussion about prognosis? Is that even information that's important to you? I always ask people, what are they worried about? They always say their family. And then I try and push them to move on from that. And then I'll ask them what they're hoping for. And usually kind of what's most on your mind is really my favorite question because it really just cuts right to the chase. But, you know, in regards to what are you most worried about, everyone says their family. And I always tell them, look, there is one thing that you definitely can do to help your family right now. And that's engage in advanced care planning. Advanced directives are incredibly important. And when I do advanced directives, what I really try and stress with patients is, look, you're not doing this for me as your doctor. I don't really care about what your advanced directive has. And you're not even really doing it for you as the patient. Who you're really filling out an advanced directive for is your family. Because if you don't have one, the worst case scenario is they end up in a conference room at the hospital while you're in the ICU trying to figure out what type of care they'd want. They'll be staring at a team of about a dozen doctors, getting a ton of information, and they're going to try and figure out what decision you would make. And so I tell folks, look, you know, this might be a difficult conversation. It might be an uncomfortable conversation, but it is such an important conversation to have. And the best time to have it is not during a time of crisis. It's when you can go to a doctor's office, ask some questions, think about it, talk to your family, share with them what you're thinking, and then go back. Because really the important part of the advanced directive is not necessarily the documents, although the documents are exceedingly important. It's more the conversation that you have with your family about the care that you would want. And study after study shows that if you have an advanced directive and you have these discussions with your family, the care that you get will be concordant with that. And not only that, after all is said and done, family members have much less in the way of emotional distress from the whole experience because they went through that advanced care planning process. So real briefly, what's involved in an advanced directive? Just 2 things. One is called a durable power of attorney for healthcare. Everyone should have one, depending on who you talk to in medicine. If you're over 18, you should have one. If you're married, you should have one. If you're over 55, if you're over 65, if you have a chronic disease, if you should have an advanced directive. And so what's involved. One is a durable power of attorney for healthcare. And really what this means is, who do you want making decisions for you if you can't make them yourself? Obviously, this should be somebody that is involved in the day-to-day aspects of your care and knows you well and can make those decisions on your behalf. If those folks or the person that you are thinking about choosing as your durable power of attorney for healthcare can't make those decisions for you, doesn't agree with those decisions for you, you think might be too emotional to engage in discussions with the physicians about the risks and benefits of interventions, that might not be the best person to pick. At the same time, some people just kind of go ahead and de facto pick their oldest child, even though the eldest child might live across the country and only comes back home once or twice a year and never really attends a physician visit, isn't really seeing the day-to-day aspects of care. That might not be the best person either. So number one, who do you want to make decisions for you? And then number two is filling out a living will, or rather, what do you want those decisions to be? And this is where you spell out, this is how I want to be cared for. This is how I want to engage with life support. This is how I feel about a feeding tube. This is how I feel about a breathing tube. And again, to be really clear, as a physician, I can tell you if those treatments are going to be helpful. I can tell you if they're going to help you achieve your goals. But from where we stand as physicians in medicine, we're agnostic about what you pick. We want to support you in getting the care that you want. We want to support you in getting all the care that's going to be beneficial. We're happy to help fill those things out, answer questions, kind of walk through a couple of what ifs. But really, most of the drawing up of a living will is you spelling out the type of care that you want. And again, this really shouldn't be a document. It should be a conversation, an ongoing conversation. And depending on how things change, you might have to revisit it. You might have to make a couple of changes to the document. And because maybe you say, look, wow, I was in a support group and I watched one of those guys go through that treatment and man, that was horrible. I never want to have that. Or you might say, geez, I would never want to be put on life support. But I guess if it was just for a short period of time, or if there was reasonable hope for recovery, maybe I would think about that. So again, advanced directives really important, but what's most important is the conversation. What palliative care does is it helps you have that conversation with your family. So palliative care helps people feel good. It helps them plan for the future. And all that's well and good, but does it actually help people live longer? One of the studies that I want to share with you, the only study I'm going to share with you because I don't want to bore you too much with academic papers, but it talks about early palliative care for patients with metastatic non-small cell lung cancer. I was actually looking at a paper yesterday that talked about cancer patients and Parkinson's patients and how there is actually a lot of similarity between the two, despite the fact that the diseases are totally not related. The effect on caregivers, the distressing symptoms that folks have, the change in functional status, all of those things are fairly similar with cancer and Parkinson's disease. So what this study did, this early palliative care for patients with metastatic non-small cell lung cancer. So what they did was there was 151 patients in this study, and metastatic non-small cell lung cancer has a life expectancy of about 12 months. So it's a uniformly fatal disease. And the impact of the treatments is pretty tough too. And so at time of diagnosis, what they said was patients could either get standard of care, and then if they involve palliative care down the line, that's great, or they get standard of care and palliative care right out of the gate. And some patients actually saw the palliative care doctor before they even talked to the cancer doctor. And so they wanted to see, does palliative care have any impact on survival at all? And what they found was that the group that had palliative care integrated into the standard of cancer care had far less symptoms. So palliative care, we say we're going to help you with symptoms, your pain, your constipation, your fatigue. And true to form with this study, they actually had less symptoms. They reported a higher quality of life. And again, that's just defined on a per patient basis and what they feel is quality of life to them. they were much more likely to have had a discussion about their preferences for end-of-life care. So they actually did go through that advanced care planning process. They received less aggressive care, so they spent less time in the ICU. They got less rounds of chemo. They didn't get those aggressive interventions towards the end of life. But what they found was that they lived almost 3 months longer. I mean, I'm going to say that again. They lived 3 months longer just by having some of these conversations, by having their symptoms well managed, by having discussions about their preferences for end-of-life care, and surprisingly to a lot of the study researchers who were all oncologists, they got less chemo, and they still lived longer, up to 3 months. This is a disease that by the time of diagnosis, people usually have a prognosis of 9 to 12 months. To live an extra 3 months is absolutely astounding. And so this is a study that's oftentimes talked about in palliative care, about the benefits of early palliative care, having symptom relief, reportedly higher quality of life, but that does not come at the expense of prognosis. And in fact, in this particular instance, the folks that had palliative care, not only did it not impact their prognosis, they actually lived longer. If this was a chemo drug, everybody would be getting it. And in fact, now that is the standard of care, is to have palliative care involved pretty much at time of diagnosis. So when should you consider palliative care? So we talked about what palliative care is. We talked about kind of what they do. So when should you be thinking about palliative care? Well, if there's any uncontrolled physical symptoms related to a serious disease or its treatment, one of the things that I oftentimes say tongue-in-cheek, palliative care is not for the 50-year-old roofer with back pain. Yes, we do pain and symptom management, but we don't take care of chronic non-terminal pain. That is a whole different medical specialty. It requires a different set of tools in the toolbox. And to be clear, I know that those folks are suffering with chronic pain, but that is not the type of pain that we manage. We take care of symptoms that are related to a serious illness or its treatment. And certainly in palliative care, we see a lot of folks where sometimes the cure is worse than the disease itself. Whether it's chemotherapy, whether it's a stem cell transplant, whether it's surgical complications from some of their procedures, that is one of the things that we do best in palliative care, is helping folks with those symptoms. As a bit of an aside here, some people say, like, why palliative care now? Cardiologists have been around for as long as we knew there was a heart, and pulmonologists just as long, internists as long as people have been suffering and needed to be healed. But one of the things with palliative care is now people are actually living longer. The diseases are more chronic in nature, and when you look at a lot of the disease breakthroughs, very few of them are cures now. All the quote-unquote breakthroughs for disease are more treatments to live longer with the disease. There's not a pill to cure you from your COPD, but there's multiple inhalers that can help your quality of life and kind of prolong your prognosis. So people are now living longer with their disease, but their symptoms are now getting worse and worse and worse. The example that I always use is that it's pretty rare that somebody has the big one anymore in terms of a heart attack. When people have chest pain, they go to the hospital. God bless my cardiology colleagues. They're in there with a stent, within about 15 minutes. They open up that heart. And so people don't have that big heart attack that takes their life, but they just suffered a major heart attack that knocked out maybe 40, 50% of their cardiac muscle. So now their heart doesn't work. So they're still alive, thank God. But now they need to walk around and live with a heart that's pumping at half as strong as it should be. So again, that's kind of one of the reasons why palliative care get involved. So when else would you get involved with palliative care? Patient or families experiencing emotional or spiritual distress, especially regarding the diagnosis or the prognosis. Everybody is really surprised when they get some of these diseases. Most folks are able to work through it, but if they're really having a hard time with that, palliative care and its interdisciplinary approach can be really helpful. If you're starting to see an accelerating need for medical care or hospitalizations, if all of a sudden somebody becomes the human ping pong ball going from home to the hospital to rehab to the hospital to rehab to home to the hospital multiple times within the course of 6 months, That lets you know that you might be needing the help of a palliative specialist. If you're thinking about declining or considering declining life-sustaining treatments towards the end, whether it's a feeding tube or a tracheostomy or dialysis, you might want to talk to a palliative care doctor as well. So with Parkinson's disease specifically, when to consider palliative care: uncontrolled physical symptoms, depression, sleep, anxiety, pain, fatigue. That's a good time to think about either discussing it with your neurologist or engaging the services of a palliative care doc. Help with advanced care planning. What does it mean to do this? What does it mean to get a feeding tube? What does it mean to go to the hospital and be put on life support? If you're having trouble kind of understanding your disease, your prognosis, I always tell people to make sure you start that conversation with your neurologist. But sometimes the palliative care doc can be a fresh set of eyes and kind of unpack that and help people process that information about prognosis. Accelerating hospitalization frequency and length. One of the other things too is that people say, hey, when I go to the hospital, whenever I come back, I feel just as good, if not better, than when I went in. Great. The hospitalization sounds like a good intervention. Let's keep doing it. But if every time you go to the hospital, you come back, you don't feel as well, going to the hospital, you come out, you feel worse, you're never quite getting back to baseline, might not make sense to be going to the hospital anymore. And the other one too, caregiver burnout. I think that taking care of somebody with any type of chronic disease, feeling burned out, it's a sign that you probably need more support. If you don't have a social worker in your neurologist clinic, palliative care is another good stop for that. So again, this is kind of the continuum of care. Palliative care involved all the way along the continuum of illness, can be engaged anytime. And sometimes on the far left, palliative care takes a back seat. The treatment of the underlying disease is the most important thing, as opposed to the right-hand side where palliative care becomes a little bit more of a focus. Quality of life becomes more of an issue because there's not as much they can do for the illness, or the benefits and risks of some of the treatments aren't nearly as clear as they are at the beginning. So this I thought was a very interesting, it's kind of the same graph I just showed you, but it's specific to Parkinson's disease now. So there's the time of diagnosis of Parkinson's disease. Treatment of Parkinson's disease on the far left, taking much more front and center approach, as it should. And then here's the dotted line that you can see on the screen. That is overall functional status. Usually kind of in that early stage of Parkinson's disease, it's a good time to start that advanced care planning conversation. Fortunately, symptoms might be minimal. Then as folks get to moderate Parkinson's disease, they might be having some symptoms, maybe some mood disorders, coping with what the new normal is, getting help with ADLs, kind of sussing out, feelings of worth and dignity when you need more and more personal care. And then finally, towards the advanced stages of Parkinson's disease, palliative care takes more of a role. Maybe you're actually de-prescribing some of the Parkinson's medicines because as your body changes, the side effects of the medicines start to change, and maybe what made sense 2 months and 2 years ago doesn't make sense anymore because the body's starting to change. And then finally, as functional status continues to decline, folks kind of enter hospice. So that's kind of one model of how Parkinson's disease and palliative care start to intersect. So another common question that we get is, who pays for palliative care? I'm going to go back to it again. It's just like any other medical specialist, like any other ologist that you have. So palliative care is usually covered under Medicare Part B. If you have a copay, you typically pay the copay for the palliative care consultation as well. If you have private insurance, it's covered under most private insurance plans as well. So palliative care is just like any other medical specialist that you can engage services with. So I mentioned the H word a little bit ago, and that was hospice. So what's the difference between palliative care and hospice? A lot of people use the terms synonymously, but they're not. I think that's one of the things I want you to walk away from this talk from, is that palliative care and hospice are actually two different things, but they definitely play in the same sandbox. So non-hospice palliative care, which is what I've been talking about this whole presentation so far, the last half hour, it's appropriate at any point in a serious illness. It can be provided at the same time as life-prolonging treatment. There's no prognostic requirement, and there's no need to choose between treatment approaches. You can have palliative care and see a neurologist. You can have palliative care and still go to the hospital. Hospice, though, is kind of like pure palliative care. And what I mean by that is it's only palliative care. It's only focused on pain and symptom management. It is not focused on the disease anymore. It's not focused on going to the hospital. It's focused on keeping people comfortable for those last final weeks to months of their life, but not focusing on the disease as much. People have to have a prognosis of 6 months or less if the disease runs its natural course, and that has to be certified by 2 physicians. What happens when folks enroll in hospice, they give up insurance coverage for hospitalizations and tests and treatments and procedures. And, but that comes with a much more robust care team. So again, hospice is care for those in the last few weeks to months of life. You have to have a prognosis of 6 months or less if the disease runs its expected course. I have had more than a handful of patients that live longer than that 6 months, which is great. Everyone is grateful for that. You don't get kicked out of hospice if you live longer than 6 months. But every day along the way, everyone still thinks that, yeah, we're looking at about 6 months or less. So I think in hospice and palliative care, we like to talk about food a lot. So if you're like me, you're probably usually thinking about food. And I thought that this is the palliative care pie. So you can see like the whole piece of the pie is all of palliative care, can be engaged any point along the disease process. But then you've got that one slice of the palliative care pie is hospice. Hospice is pure palliative care. So hospice is kind of part of palliative care, but it's not all of palliative care. So hopefully that kind of shows you a little bit of the difference between hospice and palliative care with, using one of my favorite food groups, which is to say pumpkin pie. So, but what about hospice? So hospice is actually a much more robust level of support for those who are felt to be in their last 6 months or less of life, and they choose that comfort-focused approach. There's 24/7 phone support, and there are also folks that come to your house. The care comes to you. So whether you're in independent living, assisted living, a private home, or a skilled nursing facility, the hospice team can partner with those folks, partner with your caregivers to give you help. It's not 24/7 care in the home, but there's always somebody available to you over the phone. And folks come to visit you whenever you need. It's covered under Medicare Part A. All private insurances and Medicaid have a hospice benefit to it as well. And it's like I said, it's a more robust level of support. There, not only is there a nurse that comes to see you as often or as little as you might need, there's a social worker that helps with some of the more practical aspects of things, whether it's helping people get letters for FMLA, or bring people home from overseas, or helping with banking and other types of durable power of attorney things. There's a chaplain to help with some of the existential distress that's usually inevitably going on with hospice patients, talking about things like hope and suffering and meaning, and helping folks kind of process what's next. There's a home health aide, which honestly is by far the unsung hero of hospice. They help with the tough care, the difficult care, the moment-to-moment personal care. So, we send a home health aide out, up to 3 to 5 times a week if needed, spending about an hour or so of time with the patient to help with that showering, bathing, dressing. And there's grief support to help people both while they have a loved one in hospice, but then for 13 months after, they're followed by the grief support folks within that hospice for ongoing support as they start to adjust to the new normal. And finally, durable medical equipment, whether it's a hospital bed, oxygen, a bedside commode, all that's covered under hospice. Everything from the blue pads to the medical director, as one of my colleagues say, is all covered under that hospice benefit. So, what I tell folks is that, as opposed to palliative care, which is just like any other medical service, open 8 to 5, Monday through Friday, typical office hours. They don't have 24/7 kind of on-call support. They don't necessarily have all those aspects of the hospice team in place. And so palliative care is part of it, but when folks need more and more support, oftentimes hospice is the best level of care. So again, I can't repeat this enough. Palliative care is not hospice, and to be clear, it can be applied earlier across the disease spectrum, even at time of diagnosis. It's not prognosis dependent. You don't have to have a prognosis of 6 months or less, or 12 months or less. You can get palliative care pretty much anytime. Palliative care is not just for cancer. You know, the #1 cause of death in the United States is cardiovascular disease. There's a lot of folks on my palliative care service that have cardiovascular disease, that have chronic lung disease, end-stage liver disease, and end-stage neurologic diseases. And it's not in place of life-prolonging therapies or hospitalizations. You can still get those, and you can still go to the hospital, and you can still have a palliative care team as part of your care team. It's not giving up, and I really like this, so I have to give credit to the presentation I found this in. It's not giving up. It's actually, in every sense of the word, palliative care is an expansion of care. You continue the care that's effective, you continue the care for the disease, and then you add in this extra layer that focuses on pain, symptoms, and advanced care planning. So how can I get palliative care? So my palliative care team is NorthStar Palliative Care. This is an in-home or home-based service. We see people in facilities in their homes. So we don't have a clinic, we come to you. And you can check us out at northstarpalliativecare.com. I would, if I'm giving a talk about palliative care, I have to give credit where credit is due. The VA, the Veterans Administration, has a very robust palliative care infrastructure. It's outstanding. It really does set the standard of care for palliative care. They get palliative care for all of those vets whenever they need it, and it is a very good, thoughtful, robust set of care. So if you have that veterans benefit, ask at your VA, the Detroit VA, the Ann Arbor VA. I know the palliative care docs there, they're outstanding. Most, if not all, hospitals have an inpatient palliative care team. So if you or your loved one is hospitalized, you're struggling with some of the decisions the doctors are asking you to make, raise your hand and ask for a palliative care consult. They'll come, they'll sit down, kind of talk to you about some of the things that we just kind of talked about there, and try and, you know, help you make this decision. And again, they don't have any skin in the game. They want you to get the best care possible as defined by you, and kind of talking about the risks and the benefits, talking about the what ifs, having a plan A and a plan B and a plan C. If you're in the hospital, all hospitals have a palliative care team. And finally, just ask your neurologist, ask your primary care doc, hey, do you know of a palliative care specialist you can refer me to? So I think with there, I want to stop. I want to leave a fair amount of time here for questions and kind of comments. Kind of covered a lot of ground, but you know, I think just some takeaways. Palliative care is not hospice. It's appropriate for anybody that has a serious illness, can be engaged at any time in the course of that illness process. It's like any other ologist that you have, but the focus is on you. And our focus, the things we do best are pain and symptom management, taking a look at the big picture and helping with advanced care. So with that, I'll turn it over and we'll start taking some questions.
Okay, folks, this is Mary Sue. I just unmuted all of you, so I would say please feel free to ask questions that might be easier than type chat room, or you can type your question. Okay, oh, from Tanya. Okay, this was super helpful and informative. That was just a comment. Does anybody have a question? Go ahead and ask. Let's see if we got another chat. Let's see. No. Anybody else?
I have a question.
Okay, go ahead.
If you are in the hospital, are you assigned a palliative care doctor, or can you choose one you want?
That's a great question. So the question is, if you're in the hospital, can you choose a palliative care doctor, or are you assigned the one, just whatever one that you get? I'll say usually in most hospitals, they have a palliative care team, and whichever team and physician is staffing that team is the one that you generally get. It's much like if you get a cardiology consultation or you need a surgery consultation, it's usually whatever surgeon is there. But if you have a pre-existing relationship or you've heard of someone, you can always kind of pipe up and, say something like, hey, I've heard Dr. Stellini is really good. Is he doing consultations today? Or if you've had a consultation with a previous palliative care physician within the health system, you can ask, hey, is Dr. So-and-so available to do this consultation? And they might be, they might not be. So unfortunately, you can't pick, but I always encourage you to speak up if there's somebody that you want.
If you don't feel comfortable working with that doctor, can you ask for another one?
Usually, yeah. Usually, what I tell people is that, especially with palliative care, you have to be comfortable having these conversations. You have to feel comfortable kind of talking about the care that you want, talking about your hopes and your worries. And if for whatever reason it doesn't connect, you can always either ask for another one or work primarily with the social worker or the nurse practitioner on the team or whoever you best connect with. So you can always ask. I don't know, for some hospitals, they may only have one palliative care physician. Others, they've got dozens. So it all kind of
Dr. O'Neill, I've got a question from somebody. They tried to get palliative care a year ago, called Medicare to discuss, and they were told they could only get it while they were in the hospital, and otherwise it was not available. He also approached his primary care for referral, and they said only towards end of life. So is that maybe a case of us needing to educate the healthcare community?
Great. I think that's a great question. So first of all, like I said, most palliative care has been developed in the hospital setting, and most hospitals have a palliative care team. But there are outpatient palliative care clinics. Like I said, the VA has one. We have one. I know University of Michigan has one. I think Henry Ford has one. And so they are out there, and you can get one. Usually I would probably go to your to either your PCP or your specialist. In your PCP's case here, I would just say that they were probably a little ill-informed, or maybe they just were caught off guard by the request and kind of didn't really know what you were hoping to get from that palliative care consultation. I guess I couldn't say. But most health systems have palliative care, and both in the inpatient and outpatient setting. One thing I will say is that for some reason, palliative care has kind of developed a negative connotation for some folks. And so sometimes it's called supportive care, which is palliative care by another name. There's something called supportive oncology, which is pretty much palliative care for oncology patients, but for whatever reason, they liked the term supportive better. So that's just palliative care by another name.
Also, I'd like to add, the Michigan Parkinson Foundation has a full-time social worker on staff. So if you're going down that path and they're telling you, no, it's not available, give us a call, and her name is Emily, and she can help you through that process. So call Michigan Parkinson Foundation. We have a full-time social worker. There is another question, and it's how and where do I get a living will and an advanced directive?
That's fantastic. I think that's a great question, primarily because I like where it's coming from. And so there's a couple places to go for there. One is called the 5 Wishes, is a very common advanced care planning document out there. And off the top of my head, I can't remember what those 5 are. I think they are: who do you want to make decisions for you? What type of care do you want? What do you want people to know about you? Any last kind of thoughts or things that you would want people to know if you could no longer speak to them? And there's another one kind of crammed in there. So 5 Wishes, if you do that. Most physicians' offices have them, so you can just ask for resources for advanced care planning or living wills. When you go to the hospital, most hospitals and health systems have that too, and they may even send a social worker in to kind of walk you through some of their paperwork. I know U of M had a very nice kind of packet that they would hand out to folks whenever they were admitted to the hospital. That'd be another kind of next step. Usually, if you have an attorney, as part of the kind of estate planning process, they will walk you through that. Oh, and I see somebody just made a similar comment there as well, that there's lawyers who specialize in elder law that do this. I know that when I did my estate planning and whatnot for my kids, part of that was designating a durable power of attorney for healthcare and kind of briefly going over some living will questions. I'll say, admittedly, to my colleagues in the legal system, sometimes those questions about a living will and treatments that you may or may not want, you might want to talk about them with your physician, especially if there's care that's particularly complicated, or that you're just wondering kind of what does it look like for me. Certainly blanket statements about yes or no or never can be somewhat difficult to answer. And so, but that is part of that too. So you've got a couple of different resources there as well. And then I'll echo what Mary Sue said. I'm sure that Emily, the social worker at the Michigan Parkinson's Foundation, can probably help you with that too.
Also, I believe that you can get these forms. Going to an attorney is probably a great idea. In fact, my husband and I just did this, and so we just went through the whole process. But it did cost money, and if you don't want to spend the money, you've just given me an idea that we should probably post all these forms to our website. I believe that you can do these forms on your own and get them notarized by a witness. Am I correct in that?
Yes. Mm-hmm. You
So
can
that
get,
if you didn't want to pay the attorney fees. Dave, do you know that answer?
Yes, you do not have to have an attorney write one up for you. There are a lot of free resources and examples of advanced care planning out on the internet. And Mary Sue, what I will do is I will send to you some references that we have and we use when we give presentations to the community. Hospice of Michigan also has one called Have You Had the Talk? So I'll send that to you so that you can cascade it out to your members who may be looking for it.
That would be wonderful. Thank you, Dave. So give us, folks, if you're interested in this, give us a few weeks and we'll get it posted to the website, okay?
Yep, there's another one called Prepare for Your Care that UCSF has in California. It's fantastic. It's by their geriatrics department, walks you through that process, then you come away with a document. Somebody made a comment that each state does have different rules, and that is true. So depending on kind of which state you're in, they've got little different subtleties as to, kind of what happens if the durable power of attorney and your living will conflict. And different states handle that differently. And if you're in the VA system, that's a federal system, and so they follow federal law. So that might be a little bit different too. And so sometimes those state-to-state discrepancies are important to iron out as well, especially if you spend half the year in Michigan and half the year in Florida. It might make sense to talk with somebody who kind of knows those subtle differences in each state.
also, could you maybe explain what happens when you are in the hospital and you don't have directives or a living will and you die?
Oh, sure. So I would say, what I tell folks to answer the first part of your question, when you go to the hospital and you don't have an advanced care plan or a living will, the short answer is that they are going to be very aggressive in doing whatever they can that they think is going to help you. And whether it's put on life support, have extra different procedures or interventions done. And, God bless my colleagues that do that. They're very good at what they do, but that care is incredibly aggressive. And sometimes itself can be a cause of suffering. And so generally the default is go. If you don't have one when you go into the hospital, usually when things aren't going the right way, and it looks like patients are changing, sometimes they'll call a family meeting and they'll sit down and hopefully they can kind of do that while you're in the hospital, hammer out what's going to be the care plan. If you can make those decisions, great. If not, they generally have a family meeting and kind of develop consensus and come up with the best care plan that everybody thinks is the case. But, as I said in my talk, I think that the best time to do advanced care planning is not during a time of crisis. It's when you can be thoughtful, when you can have these conversations, when you can think about them for a while and then come back.
bring.
question.
I would just throw out too that there's a website called the Conversation Project, and it gives some great hints on how to start that conversation.
Thank you. A lot of you are asking if we recorded this program. Yes, we did. If you hover over the chat, I just put the website. If you go to our website, Michigan Parkinson's Foundation, at the very top of our website, we have a YouTube icon. We post everything. We own our own YouTube channel, and we record all of our programs and our exercise classes, and they're posted on the YouTube channel. And I've got the that website address in the chat there. So just look at the chat, you'll see it.
Fantastic.
Any other questions?
This has been fantastic. Thank you.
Hi, Carol.
Hi, Mary Sue.
She's my buddy. I get to see everybody. Okay, we're just about out of time, but we've got room for one more question if anybody has it. Okay, well then I'm going to say thank you, Dr. O'Neill. This was great. Thank you, Dave.
Thank you very much.
I think this was invaluable information. We are so grateful. So
Thank you very much for having
enjoy the
us.
rest of your evening. If you have any questions, please feel free to email me and I'll go straight to Dave and get an answer for you, okay?
Please.
All right. Thank you, Michigan Hospice. We're really grateful. All right. Good night.
Thank
Good
you.
night.
Good night, everybody.
Bye-bye.
There, that's why I'm gonna check.